Welcome to the next video, first-line therapy, monitoring success, maintenance, and disease progression. In recent videos, we've been talking about the treatment in the stage 4 or unresectable setting, or referred to as palliative treatment. And we went through the mind map of how I think about treatment of this cancer in this setting. And after being newly diagnosed, we talked about a number of different biomarker-directed therapies: HER2 positive, PD-L1 positive, Claudin positive, or all negative, and their matched targeted therapies or just chemotherapy. We talked about the staple chemotherapy with fluoropyrimidine, preferably 5-FU, but also could be capecitabine, along with oxaliplatin. And so today we're going to be talking about, now that you've started this treatment, how do we monitor whether it's working or not, and what is maintenance therapy, and where is that useful, and then what would we do if and when there is actual progression and transitioning to the next line of therapy. So as a summary, with respect to what we might expect with chemotherapy, we looked at a number of different clinical parameters. Response rate, that means how the cancer is shrunk. On a scan that is a 30% shrinkage or more would be called a response. Or disease stability would be it's not growing more than 20% and it's not shrinking more than 30%. So it's between 20% growth and 30% shrinkage would be called stable disease. And then, of course, if it's growing more than 20% from when you started, then it would be called progressive disease. So together, disease control rate is those patients who have a response plus those patients who have disease control stability. And so with first-line chemotherapy, that response rate, about 40 to 50% of patients will achieve response. And adding those patients who have at least disease control, it can be up to 90%. These parameters are a little bit higher in the cases of where you're adding biomarker-directed matched therapy like trastuzumab for HER2, or et cetera. And so those response rates are a little bit higher. Progression-free survival is the time point at which the cancer has grown on the therapy. And so this is a median time point, meaning 50% of patients' cancers have learned how to grow and 50% of patients haven't. And that benchmark is usually around 6 to 7 months with chemotherapy. Again, it's an extra couple of months when you add matched targeted therapy in the respective subgroups. And then finally, the median overall survival with chemotherapy alone ranges from 8 to 12 months in clinical trials. Again, with better therapies and also later line therapies, when the first one stops working, this tends to be a little bit higher. So it usually ranges around 12 months or so in most recent clinical trials. So when a patient's first diagnosed, I tell them, odds are generally in your favor that at least for a little while, that treatment will be working. So again, more summary here, the median overall survival, best supportive care with just supportive care, pain medicine, fluids, et cetera, in the era where treatments weren't available going back several years ago, the median ranged around 3 to 6 months, just to show the severity of the problem. With the addition of chemotherapy, we can improve on that. And again, with the targeted therapies for matched groups, that median improves a few months in each of those situations. The reason why we use chemotherapy is not only then to increase the survival time, but also because it's palliative. We've talked about how the goals of treatment are really to improve symptoms or delay the onset of symptoms while trying to balance the side effects of that treatment. And all of this information has been learned over the last years with clinical trials, comparing at any given time whatever was considered a standard to new approaches. So really, I want to highlight, though, the goal of therapy in this setting, for the most part, is to not only improve survival, but really optimize and improve quality of life by limiting side effects of that same therapy. So a common question then, when patients are first diagnosed with stage 4 disease, and I'm going through these principles with them, a thought occurs that, so does that mean I need to be on therapy forever, or is this sort of a finite course of treatment? And the answer is, again, for the most part, as long as we're getting therapy and controlling the cancer, that's the name of the game, as long as it's tolerable and our quality of life is good and the side effects are manageable. So the answer is sort of, we have to be on therapy forever, but we're going to go into that a little bit more in this video. That's shown here. And again, this slide was used in the introduction to first-line therapy. And really the goal and the notion here is that we are trying to balance between controlling the cancer and limiting side effects. And when we achieve that balance, then we are achieving our goals of therapy here. Another important point to note is that most patients that are first diagnosed with stage 4 disease are able to at least start some form of first-line palliative therapy. First line is 1L here as an acronym. And so we're going to talk about after starting therapy. Now, in any of those groups that we talked about on the mind map, how do we monitor if it's working? And that's what we're going to delve into in the next few slides. So again, I mentioned that for the most part, most patients can achieve at least stability of their cancer, if not shrinkage. And so that would be considered success. So the first principle to note here is that once we start a treatment plan, FOLFOX with or without a biologic therapy, a targeted therapy, usually your doctor will plan a certain amount of treatments and then a time for an objective reassessment. So in general, on average, that is about 2 months later after, if you're getting FOLFOX every 2 weeks, that's 4 doses of chemotherapy. And so along the way, how do we decide if this treatment is achieving its goal? So the first set of factors are clinical factors, things that we can assess with each therapy, after each dose, after every 2 weeks when you go back for treatment, we will be assessing whether it's the doctor or their team, nurses, nurse practitioners, will be assessing a number of things. First of all, is the therapy tolerable? We'll be assessing side effects of the treatment, like nausea, vomiting, fatigue, diarrhea, etc. We'll be assessing laboratory values like blood counts and liver and kidney function, etc. And so based on this, we'll be assessing, is this treatment being tolerated? And if not, is a treatment modification necessary? Do we have to come down on the dosing of the treatment? And we talked about in previous videos that this is often a concern of patients and family members. Like, does that mean we're going to be compromising the effect of the treatment? And the answer in clinical trials has repeatedly shown that the answer is no. We will not be negatively affecting the effect of the cancer, but we will be making the treatment more tolerable. In some cases, by doing that, we can stay on the treatment longer and it'll work better. So we shouldn't be apprehensive about dose reductions if necessary, because in the end, again, the main goal here is quality of life, not only extension of lifetime, but also making sure that our side effects are manageable and that our quality of life is good. So in addition to that, along the way, again, with each visit with your team, we can see early signs of whether or not this treatment's working. Are the symptoms of the cancer, the original symptoms that led to your diagnosis, if you had some, are they better? And so they will be asking, remember that swallowing problem you were having when you were first diagnosed, what we call dysphagia, or pain from the cancer itself at the site that it started or at the site that it spread to? Is the pain better? Are you using less pain medicine? As less pain medicine needed to control your pain? Is the symptom of early satiety, remember that means getting full quickly, is that improved? Are you able to eat better and eat more? Is your appetite improved? Are other symptoms of your cancer that you presented with, like bleeding or nausea and vomiting, are any of those better? And so these can be early signs that the treatment is already working. And we can see this even 1 week after starting the first dose in many cases, that all of these symptoms may start to be getting better, and in some cases, completely better and resolved. Now, in addition to that, of course, there will be objective measurements. Can we, other than the subjective things that we can assess and get from you, what about objective things that we can measure? And so the first class of that is laboratory values. We talked about early on tumor markers in the blood. And in many cases, they can be elevated, the CA19-9 and or the CEA. And in a lot of cases, they're both elevated, and sometimes one is elevated and one is normal. Either way, we would be following that. And if they were high and they are now trending down with treatment, that would be a good sign, an early sign that things are improving. And it varies in different practices in terms of how often these are checked. At minimum, it's every 2 months, but some check it basically with every dose of treatment, so every 2 weeks. And so you can start to see these trending right away. Another way to measure in the blood would be looking at circulating tumor DNA trends. And we talked about that a little bit in previous videos, where we can see that this is even more sensitive in many cases, even though in some cases tumor markers may be low right from the get-go. In some patients' tumors, the ctDNA can be elevated at baseline, and so trends of those can be followed. So if they're dropping, then we would see that there's early signs of improvement. And then finally, imaging. This is the most objective way of assessing whether or not the treatment is working, and that is looking at CT scans, usually infused in the IV, giving contrast and oral contrast to help the radiologist really look at what we were starting with, and then after a period of time, in this case 2 months, is there improvement? And so looking at this every couple of months is sort of the final sort of say in terms of whether this treatment is working or not. So taking all of these things together, all of these factors, your doctor will then meet with you after those first few months of treatment and put it together, this puzzle of clinical factors, how you're tolerating the therapy, your symptoms from the cancer, and then the objective analysis with the labs and the CT scans to really assess whether or not this treatment seems to be working. And at every time point of this assessment, every couple of months, I explain to patients that there's a fork in the road in terms of what we're going to do next. And it's going to be based on what happened and what our assessment is based on these factors. And so if everything seems to be going very well, tolerating therapy well, the treatment seems to be working well, then one option might be to continue exactly as we had for another couple of months. On the other hand, if, for example, there is some side effect that we're not liking, it's causing a lot of nausea or fatigue, tiredness, then we may elect to dose modify the treatment, adjust the dosing down a little bit, but still continue on the treatment because objectively the scans and the tumor markers and symptoms, for example, are getting better. And so we may continue, but with a slightly modified dose. We're going to get to talking about what we might do in the setting of a more drastic modification, which is called maintenance therapy, where we stop the second drug, the oxaliplatin, and continue with just the 5-FU and or the targeted biologic therapy if indicated and appropriate. Or if there's a situation where the cancer is growing, for example, despite the treatment, or it's too intolerable despite modifying the doses, then we may elect to switch to an alternative therapy and try that. So at every reassessment time point, we'll be taking all these factors into account and making a decision on what to do next over the next segment of treatment. So that's how we assess whether our treatment is successful and whether it's working. And so let's take for the example where we first started treatment, you were just diagnosed, you had your first couple of months, and everything looked like it was going very well. We would probably elect to do at least another 2, if not 4 more months of the same. Now, at the same time, if we were to then reassess after those couple of months and everything was still looking good, where we didn't have any side effects, we would be worried that there may be cumulative side effects. People can't be on this treatment indefinitely with what I refer to as full dose chemotherapy with the 5-FU and the oxaliplatin, with or without the targeted therapy if appropriate. And so eventually, usually after 4 months, certainly by 6 months, we'll be starting to think about dropping the oxaliplatin out to limit cumulative neuropathy, the main issue with long-standing dosing of oxaliplatin. Certainly, if there's obvious side effects that are sort of affecting your quality of life negatively. Like, for example, you're having a lot of fatigue and you're, in bed most of the day for the first week of the 2-week cycle. This is not the goal of therapy. This is not what we're looking for. We want to balance the side effects with the control. So let's say in that scenario, the treatment seems to be working very, very well. The cancer is shrinking, the tumor markers are dropping, your symptoms have improved or resolved, but you're having these intolerable side effects. Then we're talking about dose modification, and we're going to get to the concept of maintenance therapy. So what are the reasons for maintenance therapy, and what is that? And so this goes back almost 20 years now in colon cancer literature, but it's been extrapolated from that and applied to gastroesophageal cancers. And that is, at the time, even when this new drug oxaliplatin first came around in the early 2000s, was that it seemed to be pretty effective in a lot of GI cancers like colon, gastric, etc. But it was starting to be realized that there was neuropathy. And that neuropathy, I explained to patients, as we've talked about, can be in the form of numbness and tingling in the fingertips or the toes that is built up over time and cumulative. And so it gets worse with each dose. And then there's the other type that is sort of immediately, even after the first dose, and that's the cold sensitivity that lasts for a few days, but then dissipates over time all the way. And so the more concerning one is the one that's sort of built up over time, and that will still be there and linger there despite even stopping the oxaliplatin. And so strategies to try and limit that neuropathy evolved, and this is called Optimox, so optimizing the oxaliplatin. And this was the first study of assessing this in colon cancer, and that was the traditional way of doing it was just start FOLFOX and just continue till it stopped working or it was completely intolerable. Just keep giving the doses every 2 weeks. This study assessed doing that as the control arm versus a planned stop and go of the oxaliplatin part, and then continuing with the other agents, in this case, just 5-FU. So you can see in this figure, you would start with FOLFOX, and in this study, it was for 3 months worth of treatment, 6 doses, and then a planned stop. If you were shrinking, partial response, or if it was stable disease, you would drop the oxaliplatin and just continue for 3 months with just the 5-FU. And then whether or not there was, when the cancer progressed or had showed progressive disease, then you would resume the oxaliplatin, add it back on, and continue it, and keep doing that over time until you had progression on the full chemo FOLFOX, or you couldn't resume the FOLFOX at the time of progression on maintenance because there was worry that the neuropathy was too bad and that we didn't want to make it worse. And so the idea here was maybe we can extend the longevity of using this oxaliplatin drug because we're not giving it all the time, and maybe let the nerves in the hands and the feet sort of recover a little bit before re-challenging with it. And so this study was pivotal because it in the end showed that by doing this, number one, it didn't cause as bad neuropathy as just continuing the FOLFOX, which is common sense and makes sense. But most importantly, it didn't compromise the effect of the treatment. Patients had the same overall disease control. The time point at which full FOLFOX was considered no longer effective was the same. And so by doing this, we could have similar control for the same amount of time, but less amount of oxaliplatin and less neuropathy. So based on that Optimox 1 study, that principle sort of extrapolated to other tumor types, and we routinely do what we refer to as now maintenance therapy of just the 5-FU with or without the biologic therapy if appropriate, and to limit that buildup of neuropathy. And again, most practices will implement this by 4 months into treatment, or at minimum after 6 months. And so an example and of a reason for doing this then is that in the setting of where you're doing really well with full first-line therapy with or without that targeted therapy, and the cancer is either stable at minimum or even shrinking, but you're developing or you have this oxaliplatin neuropathy, of course, you would start implementing maintenance. Also, an important one is you haven't yet developed long-standing neuropathy, or it's very, very minimal, but the physician is concerned that with more doses, it will kick in. And so by dropping the oxaliplatin now, we can preemptively prevent that from happening and going to maintenance. And remember, we've talked about oxaliplatin. The tricky part of it is that it's a lagged onset of the neuropathy. And so even though you feel great after 4 months and you don't really have a lot of neuropathy, we know that those first 4 months of treatment still haven't all kicked in, and that the effect of those may not be realized for another couple of months, even 3 or 4 months later. And so you sort of have to consider stopping it now, even though you're not really feeling it yet. And so that's always a tricky discussion because patients feel well and they don't want to negatively affect their treatment. But we know it's coming just based on experience in trials like this. And so we can preemptively drop it after 4 months, even though there's no sign of neuropathy yet, but we know it would be coming, even with no further doses of oxaliplatin. And so another situation may be that you're not tolerating the oxaliplatin well. You're having other side effects outside of neuropathy like nausea, vomiting, fatigue, etc., which in the FOLFOX regimen, usually the culprit is the oxaliplatin, not the 5-FU, if you're not getting a 5-FU bolus. We talked about the 5-FU bolus versus continuous infusion, and FOLFOX 6, the regimen called FOLFOX 6, has both a bolus and a continuous infusion. And a lot of physicians start with that. If you're having side effects on that regimen, especially early on, especially like nausea and vomiting, the culprit is usually the bolus. And I explained in previous videos that I usually don't even start with any bolus. But certainly if you're already on a bolus, you're getting a shot of it in the infusion center before going home. That's what we would stop first of all. But then if you're not on the bolus anymore, that's called modified FOLFOX 7. So you're getting the 5-FU just as a continuous infusion for 2 days and the oxaliplatin once every 2 weeks. It's really the oxaliplatin that would be causing the side effects after removing the bolus. And so in this setting now of you're not tolerating therapy well, but it seems to be working on scans and symptoms are better, then of course this would be the opportune time, if it's been around 4 months, to just stop the oxaliplatin, improve the nausea, vomiting, and other side effects that it might be causing, and go to maintenance because it seems to be working well. Another aspect to consider here is going on what I refer to as a complete treatment holiday, or as shown in here, a chemotherapy-free interval. And so this is an example of a complete removal of all treatments for a period of time. Now, usually I won't do that for very long, only about 5 or 6 weeks, just to give yourself a break, recuperate, and to let your blood counts recover, for example, to let your stamina recover, and just for peace of mind, just to like get away from it all, if you can afford it. And so a second study called the Optimox 2 study assessed that question, whether maintenance therapy versus a complete free interval of chemotherapy would be also something that wouldn't be detrimental but could be useful. And so in that study, generally speaking, in patients that are having a nice response, that are doing very well otherwise, could afford a little 6-week holiday from all the treatment. Usually I don't consider doing that until it's been at least 6 months into treatment from the time of starting, just to really like let the treatment sort of really knock the cancer down and put it on its back leg before we start considering full treatment holidays. But this is an answer to the question that we started with from patients is, do I have to be on therapy forever? And the answer is sort of, but we can build in breaks when we can afford them, when we think the cancer is stable enough that we can take a little bit of a break. And so this is a judgment call, and it again is based on the assessment of the clinical factors and the objective factors, and not everyone can afford that, but when we can, certainly we would like to take it. So these would be reasons for considering maintenance or chemo-free intervals along the way. So again, let's say we go on to maintenance therapy after 4 months. Then what do we do? Well, again, the treatment plan will be then set for the next couple of months on maintenance, basically treatment, everything you were getting before minus the oxaliplatin. And again, along the way, we'll be assessing how is therapy tolerated. Usually therapy is a little bit easier once you drop the oxaliplatin. And how are your symptoms? Maybe by then already the symptoms have improved significantly, or in many cases resolved altogether. And so now we're going to be assessing, are they starting to recur? Are they starting to come back? We want to catch it as soon as they are, because then it would be time to do something about it. And then, of course, we'll be assessing the laboratory values. And in the case of when it started working, maybe they dropped to begin with, but now we're assessing to see, are they starting to incrementally increase with each visit? Because then that would be signs that it's starting to come out of its hibernation and it's time to resume more strong chemotherapy. And then, of course, the objective time point after a couple of months is another scan. And then your doctor, again, will be putting all this together and making an assessment what to do next. Do things still look really good? Can we continue on just maintenance therapy? Do we need to modify more? Is it still not tolerable, but at least it's working? Can we cut down the dose of 5-FU if we need to? Not common, but sometimes that's required. Or is it time to reintroduce oxaliplatin? Am I worried now? Are symptoms starting to recur, and or are tumor markers starting to go up, and or are there concerning signs on scans? If that's the case, then maybe it's time to come out of maintenance therapy and go back onto full chemotherapy. Or am I concerned enough that I need to change altogether to something new? Or is it problematic to reintroduce oxaliplatin because despite stopping it, the neuropathy's kicked in and I don't want to make it worse? So all of these things are going through your physician's mind as to what is the next best course of care based on what's just happened in the last couple of months. And this is an example of where reporting your symptoms to the team is really important, as well as communication as to what the objective tests are doing so that we can make an informed decision what the next best step is. And so now we're talking about we're coming out of maintenance therapy and going on to full therapy. And so eventually on maintenance therapy, or certainly on a chemo-free holiday, we will eventually expect growth on this maintenance therapy. It may not be for 6 months, it may not be for 12 months. Some cases are on maintenance therapy for 2-3 years. But eventually, in most patients, we will expect there will start to be growth again, and there will be some time to do something about it. So as an aside, we in our patient calls, and certainly with patients in the clinic, we see those patients that have these extreme responses to therapy and that they don't have any evidence of disease on scans. And they're in this really excellent category where, you know, they're either on a maintenance approach or even on holiday now, and the holiday is continuing without any further growth of the cancer. And so the question is like, what do I do now? And the first answer is that from most physicians, well, this is a good problem to have, that there's no growth, we can barely see it or we can't see it on scans, and your current approach seems to be working, whether it's a chemo-free interval or it's on maintenance therapy. So why rock the boat? We're in a good place and everything is going well and we're in balance. It's only when we see growth on scans or with symptoms or with tumor markers that we will start to say, okay, it's time to do something because we are now out of balance. And so when that happens, the first question will be, well, can we go back and resume our full first-line chemotherapy with oxaliplatin or not? And so this is just to show you some examples of tumor markers. And this is a slide we used early on when we were talking about diagnosing the cancer, and that we can see elevation of certain tumor markers in the blood, CEA or CA19-9, and these are their full names as opposed to the acronyms. And every lab has a normal range. So when it's above that, we can say it's abnormal, but it really, it can help with diagnosis if it's elevated, but most importantly, it's used to trend over time because their interval changes and trends are really helpful in terms of seeing whether or not the treatment's working. So on the right side, we see an example of a patient who had both CA19-9 and CEA elevated at their diagnosis, and then after starting therapy, they dropped substantially to normal ranges, and then a long time went by before they started to go back up again. And so often these markers go up before a patient experiences worsening symptoms or before we see it on scans even. But it's sensitive in that way that we can start planning what we're going to do. I see that the tumor markers are going up. It's starting to think about resuming oxaliplatin in the setting of where this was all on full FOLFOX, and then FOLFOX came off to just maintenance, and now we're on maintenance for a long period of time, and now we start to see some growth. Now it's time to start thinking about resuming oxaliplatin. This is a second example of a patient who had elevated CEA, but normal CA19-9 at the beginning. And so the CA19-9 is always normal and not really that helpful, but the CEA is helpful. So this is an example of where that's why we check both, is because one may be high, but the other one normal, and vice versa in the next patient. And then this last part over here is just to point out that in some cases, and we've talked about at length here in various videos, that the diffuse type gastric cancers and peritoneal only cancers very often, more often than not, don't have elevation of the tumor markers even at the beginning or ever. And so they're really not that helpful. So every patient is different. And so we try and piece together as many of the variables when we're making our decisions. And certainly if they're high to begin with, these will be helpful to follow over time, because then they can help make decisions at every time point where we're going to be changing therapy or not. And so what would be the reason to resume full first-line therapy if you were on a maintenance therapy approach for a while? Well, the obvious one is if the cancer is growing, whether it's clinical symptoms or objective symptoms or both. Objective things like laboratory values going up, like the tumor markers I just showed you, and or scans showing growth, and or worsening symptoms. So any or all of these would help to push the physician to recommend resuming full oxaliplatin. This would be done if you were able to resume full therapy with oxaliplatin, i.e. you didn't have residual neuropathy from the prior doses you received, or it was considered limited, and we're not too worried about it, at least for right now. And so let's say now we resume the FOLFOX chemotherapy. We do the same thing. We do that for a couple of months. We reassess things along the way. Is it tolerable? Are there symptoms? The laboratory values and the CT scans, and we put it all together after those couple of months, and we make a decision because we're at a treatment point. So do we continue? Do we modify the dose of the oxaliplatin? Do we cut it down but continue on it? Or do we drop it off again and go back to maintenance? Do we feel comfortable doing that at this particular time point? And again, that's all based on these prior assessments that are going on in real time after every dose, and certainly after the planned course of 2 months on average. And so this is an important thing to consider, is that if there are signs that there's growth before you get to the full 2 months of therapy. Let's say, for example, you embark on your treatment and you start to have worsening symptoms from the cancer, and or the tumor markers are trending up, and you've only had 2 of the planned 4 treatments. The physician may be notified, because they often only see you at the time of scans every couple of months, and other members are seeing you along the way. But if there are worsening symptoms, the nurses or whoever you're reporting to may notify the doctor. There's some signs here that are worrisome. Perhaps we will move the CT scan earlier than what was originally planned to really make a more formal assessment, because we want to catch that growth early and make a change if we need to. And this goes for any situation, whether that 2-month plan is full chemo, whether it's maintenance chemo, or whether it's a chemo-free interval. We want to be able to interject, and we don't necessarily have to go to the full originally planned course. If we feel like the treatment's not working, we want to scan, confirm that it's not working, and then change. Okay, so that's an important point to recognize for any of the situations, for any treatment, whether it's first line or later, is that along the way, things can be changed if necessary. So let's take this scenario now that eventually the cancer will grow on full chemotherapy. So, with or without side effects from the treatment, even if it's being tolerated absolutely well without any side effects, but we have evidence that the treatment's not working on scans and or lab values and or symptoms, then that would be grounds to change. Similarly, if we have progression of the cancer while you're in a maintenance phase, but you're not able to continue the oxaliplatin because worried about neuropathy or other less common things like an allergy to oxaliplatin, for example, which can occur, or other side effects that are just not tolerable despite lots of dose modifications of oxaliplatin downward, and you're still having them, this would also be a reason to consider changing to the next line of therapy. So the main points of this whole video about maintenance therapy is that maintenance therapy is there to limit side effects, to extend the duration of first line therapy's benefit, but that eventually we expect that maintenance therapy will fail and that full FOLFOX therapy will fail, or even though FOLFOX therapy hasn't failed, the cancer hasn't grown on it, we just can't continue it because the worsening neuropathy is not possible. So we will have to change at some point in most patients. Now, remember, there's that subgroup of patients. It's relatively small, unfortunately, but there's a real subgroup of patients that just never have disease progression on first-line therapy for long periods of time. And that's the so-called plateau of a survival curve that just never really progresses. And that's a good scenario to be in, but we also have to recognize that the majority of patients eventually will have disease progression. And so at some point, we'll be talking about changing to the next line of therapy. Why? Why do we expect this? Well, with experience and lots of evidence, eventually the cancer does become resistant over time. Resistant is the word we use to say it's been treated for so long with this same treatment that the residual cancer cells that are left in your body are now able to grow despite the chemotherapy being around. And so you could keep giving that first line therapy all you like, but it's not effective anymore and the cancer will just grow. It's not a good idea to continue that. And so remember, as a sort of reminder of what we might expect with first line chemotherapy, is that a large proportion of patients will have shrinkage at the beginning of their cancer, and a similarly large proportion of patients will at least have disease stabilization. It won't be growing. But there is a small percentage of patients that right away, after the first 2 months of FOLFOX therapy, it'll just grow right through it. And so it's not common, but it is recognized that a small subset of patients will have just inherent resistance to chemo. And so similarly, there's that subgroup of patients that have exceedingly long control of the disease with the first line therapy. So they're amongst these patients usually that have a nice response, but then eventually in all of these patients, even that have disease control to begin with, eventually it will start to grow. But there's that small subgroup there that really has a long disease control and for years, and it just never really grows. And so we'll talk about that a little bit more in the oligometastatic video that's upcoming with respect to being a little bit more aggressive with these patients. But suffice it to say now that we're happy that this subgroup exists. It's not as common as we would like it to be, but in those patients, the current standard would be stay the course and don't alter the course, especially if it's a chemo-free interval and the disease is stable. Just stay off chemo. We'll just keep monitoring. Or if you're on maintenance therapy and it's stable and it's tolerable, then we're in balance. We're having a good quality of life. We're controlling your cancer and our goals have been met. So again, over time in the most patients though, that even if you have shrinkage to begin with, over time, we will see resistance to that given treatment. And remember, the progression-free survival median, that is the time point at which 50% of patients that get diagnosed with this cancer and start first-line therapy, their cancer will become resistant, where 50% is not. That time point is around 6 to 8 months. And so eventually, we would expect it to grow in most, if not all, patients. whenever it occurs, this is how I frame it, is whenever it recurs, if and when it does, that's when we'll deal with it, and we will discuss other options like moving to second line therapy when it's appropriate. When we do that is if they're still well, strong enough, we call that performance status. And of course, they're still wanting more therapy, then we would talk about moving to the next line of therapy. So the reasons then to change the second line therapy is, of course, if your cancer is growing despite the full first line chemotherapy with or without the targeted therapy if appropriate, or there's obvious progression on first line maintenance, which is the 5FU alone with or without the biologic therapy, targeted therapy if appropriate, and you're not able to resume or come out of the maintenance back to full FOLFOX because you have neuropathy or other reasons, that would be time to switch to second line. This last one is another one we've been alluding to in previous videos and even earlier in this video, and that is you may not have obvious progression on scans or tumor markers, but there's a concern that there's progression. And an example of this is with peritoneal-only disease, diffuse type gastric cancer, where this is coming from experience with the physician who treats this type of cancer a lot and frequently, and they can tell when the cancer is starting to grow based on other factors, clinical symptoms, for example, where patients are having more cramping, patients are having more early satiety, they're getting full quicker, they're having bowel movement issues, maybe because there's obstruction of the gut, or it's not mobile like it should be. These would be evidence that there's progression inside the peritoneal cavity despite scans and other parameters not being able to detect that. And so there may still be signs and reasons to switch to the next line of therapy, even if all of the things that we normally do aren't picking up evidence of progression. And patients with peritoneal-only disease, they know this and recognize this as an issue. So overall, then, we've talked about here balancing treatment, the goals of therapy to optimize quality of life and keep us in balance with treating the cancer, but also limiting side effects. And if we're pushing it one way too much, we can back off. If we're pushing it the other way and the treatment's not working in a number of different situations, eventually it will be time to switch to next line therapy, which is the subject of the next video. So again, we've talked about first line therapy and what we do now to monitor it, to determine whether it's working, whether it's successful, and to make decisions along the way, usually every couple of months, in terms of treatment decisions and changes if necessary. And eventually, in most patients at least, we'll be talking about a switch to the next line of therapy, which we'll talk about in the next video. So again, in this video, we talked about first line therapy monitoring success, maintenance, and disease progression. Stay tuned for the next video on second line therapies and what we do in those situations. Thank you.